Hello, I'm Andrew Susskind, and I'm a psychotherapist and author based in West Los Angeles since 1992, specializing in trauma and addictions. Welcome to our podcast, which I call It's Not About the Sex, also the title of my recent book. Here we focus on all topics related to compulsive sexual behavior, often referred to as sex addiction. In particular, we explore ways to build long-term, sustainable recovery while establishing more meaningful connection and greater intimacy. Our intention is to offer fresh viewpoints, brand new perspectives, and practical user-friendly tools toward living a more deeply connected life. Let's get started. Today, I'm so pleased to have my friend and colleague, Dr. Tracy Zemansky, join us. Dr. Zemansky is a licensed clinical psychologist, a licensed marriage and family therapist, and a clinical sex addiction therapist and supervisor with a private practice in Santa Monica. Since 1994, she does clinical, forensic, and occupational psychological assessments, as well as depth psychotherapy. Dr. Zemansky is one of the few LA-based psychologists doing collaborative therapeutic assessment, a process that uses psychological testing as a brief, dynamic intervention, helping clients and referring therapists address diagnostic challenge and entrenched patterns. She is also a founding member and current president of Pacific Assistance Group, the sole comprehensive support and monitoring program for impaired healthcare providers throughout California. Dr. Zemansky received her Ph.D. in clinical psychology from Fielding Graduate University in Santa Barbara and has studied under Dr. Patrick Carnes for her certification as a clinical sex addiction therapist supervisor. Welcome, Tracy Zemansky. Thank you so much, Dr. Zemansky, for being with us today.
Thank you so much for having me. It's a pleasure.
It's such a treat having you here today. And one of the things I just wanted to add to the introduction is that truly Dr. Zemansky is part of a small group of psychologists that helps treat impaired healthcare professionals. And that's what we're going to be focusing on today. And one of the things that we're going to be focusing on is something that Dr. Zemansky calls the slippery slope. And it has to do with sexual misconduct and sexual boundary violations, but more specifically, how to help these folks who just run into these roadblocks in their careers. So again, I'm just so pleased to have you here to talk about this super important topic. And I'm wondering if you could start off to describe what you mean by the slippery slope that can lead to sexual boundary violation.
The slippery slope is something that can easily happen to any of us. It's kind of the gradual progression of boundary violations from the most subtle and non-sexual, like offering to give a patient a ride when their car broke, to frank sexual involvement. It's usually a process that happens gradually and oftentimes without being premeditated at all.
Can you say more about that? When you say it's not premeditated, how does that happen? How does the slippery slope seem to happen without intention?
Well, so you take a patient that is coming and asking for help, and you have a very stressed physician who maybe doesn't have the best self-care, and they have a nice conversation. They're joking, they're enjoying each other's company, even though it's perfectly appropriate within the professional setting, but there's just that little edge of perhaps friendship that, for some professions that's acceptable. For others, it actually isn't. Maybe a patient brings some homemade cookies. Maybe there's an offer of, hey, could you just look at my daughter real quick after hours? And then I would be so grateful. Maybe there's an excuse to waive a copay. Again, in the beginning, it could be something that's very simple and well-intentioned, but with increased stress and increased frustration, and who knows what's going on in the home lives of these two people, maybe the doctor-patient relationship gets shifted and their doctor-patient friend relationship. It could be that the physician is not intending anything other than compassionate care and gives the patient, a pat on the shoulder or a hug. And then there's a perception that that is more romantic than maybe is initially intended. So when caretaking or support goes past what would be considered appropriate professional boundaries, then things can slide with increased, really, stress and lack of self-care to something that the boundaries start to get blurred. And it may not be exploitive, like loaning a patient money, but it generally starts to shift that balance. And now there could be something that is more overt, like having an appointment in the later part of the day so that the office staff is now gone. There may be rescue fantasies on both patient and physician's part, and it's purely the physician's responsibility to hold the boundaries. But, physicians are people too and have the same kinds of issues that all the rest of us do. So it can move from something that seems innocuous and not planned to really a double bind where there's now a secret and there's now a power shift. And the patient may not feel that they're in power, but of course, if there's a problem and the physician is the one who's responsible for that, then the patient now is in a very different role.
Wow. So in other words, it can start out quite subtle.
Yes.
And neither party may be aware of the movement towards some kind of boundary violation, but it can sometimes expand or grow from there. And the word that came from me is that there's a certain intimacy built into the relationship sometimes. There's a vulnerability, there's an intimacy, and then sometimes it goes too far. And I think that's what we're talking about today. Is that right?
Yes, because there are different types of boundary crossings that, like I was saying, giving a patient a ride if their car broke down and it's raining. That could be completely intended in a kind manner and with nothing else on anyone's mind. So it's already a boundary crossing. It doesn't mean it's a problem, but with increased, stress or lack of self-care or overwork or substance use, all of those things are vulnerabilities, and the stress and exhaustion and the demands from work and family and finance and the changing, field of medicine, and perhaps the lack of other support system, it becomes problematic.
Sure. And I really appreciate some of your language. And I was wondering if you could share more about possibly an example of a boundary blurring versus a boundary crossing.
A boundary blurring would typically be where the physician's role overlaps with other roles. Typically, this isn't exploitive, and typically it doesn't harm the patient, although it might if it gives the patient ideas about something that isn't intended. So let's say the physician has a child who's the same age as the patient's child, and they both are on the soccer team. The physician and patient might see each other in a setting that's completely outside the professional setting, and it might be completely appropriate. Well, what if the patient is now the coach of the soccer team and the physician's daughter is on that same team? Again, it's not necessarily problematic, but it does have the edge of there's two roles there. With boundary crossing, sometimes they're benign. like giving somebody some money for cab fare if their car broke down. It might be perfectly appropriate for a physician to share a personal story about something that relates to what the patient is going through.
Mm-hmm.
That's not necessarily problematic, and it might indeed be really good doctor-patient relationship and help that patient in ways that with a more neutral stance might not be so helpful.
What I was wondering is when the boundary crossing happens, you mentioned the idea of it becoming problematic. So, can you be more specific and share a little bit about what kinds of problems doctors will face after a boundary crossing?
Well, the first level would be something that would be considered an impropriety, where it's somehow disrespectful of the patient's privacy, maybe leaving the door open when the physician needs to go get the nurse, for example. Or it may be looking at the patient in a way that feels uncomfortable to the patient. So there's something that's over the edge, but could easily be denied and could be said that this is not anything intended. It's not a problem. There's no contact. There's nothing that's overt.
Mm-hmm.
It could be, but from there, it could be more of a transgression where there's inappropriate flirting or seductive behavior or touching the patient in a way that is definitely beyond normal physician patient touch. And the fact
Mm-hmm.
that physicians are touching patients' bodies easily
Mm-hmm.
leads to overstepping.
Mm-hmm.
A violation, regardless of who initiated it, is the physician's fault. So when there is frank sexual contact or sexual behavior, obviously that's the boundary has been completely broken.
So, really, there's a line that gets crossed that is not only problematic, but it's harmful. And it sounds like what you do is you actually get um, referred folks like this at the time that they have been caught, basically. Is that right?
Actually, the best referrals that I get are people who are on the verge of being in trouble but are not yet in
Mm,
trouble,
mm,
so that we can do early intervention and prevent any patient harm and help the physician to address whatever the problems are, whether that's, substance use or an extremely stressful, family situation where the physician's taking care of children and elderly parents in addition to working, a 60-hour work week,
right.
and help them see more clearly what's going on and address whatever those needs are that aren't getting met in healthy and appropriate ways so that patient harm doesn't happen. When patient harm has already happened, it's
Mm-hmm,
very similar to, anybody who, let's say, gets a DUI. So
mm-hmm,
the problem has happened, the legal situation is now involved, which is not always the case, but the problem has occurred.
mm-hmm,
And there are potential, very serious consequences for anybody with a medical license or any professional license when a boundary violation has happened, both legally as well as professionally. Physicians' code of ethics starts with the Hippocratic Oath,
mm-hmm,
and that includes the statement, I will abstain from all intentional wrongdoing and harm,
mm-hmm,
especially from abusing the bodies of men or women.
mm-hmm.
And that the relationship between, patient and physician is based on trust. And so there's a obligation on the physician's part to honor that trust and not harm it.
I'm so glad you clarified the early intervention piece. Because number one, I wasn't aware that that was such a significant part of the work you're doing. But also, I was curious if you could share a little bit more for our listeners about what kinds of things you actually help the physicians with in terms of early intervention and prevention.
The work is typically very similar to the work of early sobriety for any other behavior or substance. When there's been a boundary violation of any kind, we have to back that up and look at what was going on that promoted that type of behavior.
Mm-hmm.
Where are the stressors? Where are the lack of awareness? Where's the lack of awareness? Where is empathy being used in the wrong way? Where
Mm-hmm.
is the physician's need to be needed problematic?
Mm.
There's so many ways that physicians are, trained to be helpful, and they're trained to be understanding, and they're trained to be in charge and to be, definitive about knowing what is best.
Mm-hmm.
And patients are coming with a reliance on a physician, and that can be very powerful and very heady. And
Mm-hmm.
that need to
Mm-hmm.
be needed is something that most human beings share. And
Mm-hmm.
we all like to be acknowledged. And sometimes that sense of being helpful or being acknowledged goes awry.
Mm-hmm.
And not unlike somebody who, likes to go to Vegas a couple times a year and gamble, or somebody who likes, a glass of wine with their dinner.
Mm-hmm.
And
Mm-hmm.
then you put the right combination of stressors and lack of other available tools that the person's willing to use or knows about using or has any experience with. And there's a setup, and the problem can manifest in so many different ways. And I think the burden on the professional is that they have a standard of behavior that is above and beyond what many people would need to be paying attention to.
Mm-hmm.
But they do need to pay attention because there's so much, responsibility and trust.
Absolutely. And, I was thinking locally at UCLA, there's a doctoring program in their medical school to help the students. I call it have better bedside manner, but I'm sure there's more to it than just that. And I was wondering if you have any theories or any thoughts about what's getting missed. I mean, why are physicians not getting? Why are they getting into trouble? Basically, what's happening that's preventing them from getting the kind of training and support for themselves that results in boundary crossings?
You know, physicians are trained to be responsible and to take on things that most of us wouldn't have to ever consider. They're supposed to be empathic, they're supposed to
Mm-hmm.
be altruistic, they're typically curious and intelligent people. They're typically very high achievers.
Mm-hmm.
There's an undercurrent, or maybe an overcurrent, of compulsivity and fear of mistakes. And in medical school, because of the demands of the training
Mm-hmm.
and the literal lack of time for healthy self-care, those qualities can shift so that perception of being intellectually superior or expecting superhuman efforts out of themselves, which are beyond, you know, realistic.
Mm-hmm.
Um, the denial of trauma.
Mm-hmm.
Physicians are trained to, first year medical school, you know, gross anatomy. Physicians are dissecting human bodies. That is a
Right.
very powerful and very intense experience that most of us never have, and most of us will be glad to never have it. And
Mm-hmm.
in order to do that, they have to learn, or in order to do surgery, or in order to do painful procedures of any kind, the physician has to be able to detach themselves emotionally, or they wouldn't be able to do the job. So, we don't want our physician to be like sobbing in the middle of the floor because they have to do a surgery and cut somebody open. We want them just to be like very clear, and they're like, okay, this is what I need to do, and this is what I'm doing. So some of those experiences that require the physician to put their emotions not just to the side, but really behind a locked door, it can be hard to turn that off. So now you have somebody who's dealing with, the regular stressors of life, just like the rest of us, but that part of them that might be vulnerable or open to asking for help or able to, cry over something that's sad or painful is now shut away. So what do we do as human beings when we have no access to those parts of ourselves? We start to compensate.
Right.
And again, physicians are no different than anybody else. And what they might compensate by is maybe they're working harder, maybe they're working longer hours, maybe they're having 3 glasses of wine when they go home just to get to sleep. And just like with any other compulsive addictive behavior, it can take on a life of its own. And because their physicians are so used to not asking for help and being in charge, it becomes a double bind. And they're kind of stuck either way.
2 things jumped out at me as you were talking. You were talking about the trauma that they witness in their patients. But what we didn't actually talk about is that they may have their own trauma background, as many of us do in different ways, whether it be relational or developmental or specific trauma. And part of what is kind of sad for me as you're talking is that as psychotherapists, we have clinical supervision and consultation. And I know for me, it's part of what I do all the time because I want to stay sharp. I want to stay clean with my own issues. And I want to make sure that I'm processing whatever's coming up for me in my practice.
Exactly.
And I think what you're sharing, which is really kind of startling to me, is that physicians don't necessarily have that built into their profession or their professional community. Is that right?
That is absolutely correct. And it's one of the reasons that I find my work with healthcare professionals so profoundly satisfying, is because there is a deep need to come out of that loneliness and isolation and to be able to talk to colleagues about really what's going on and about those past hurts, about the struggles that they can't discuss, because of HIPAA and confidentiality. Where could a person go to talk about, an adverse outcome for a case that maybe there was no fault of the physician, but people sometimes don't heal. And different specialties are dealing with that kind of onslaught of emotional pain that they're having to help on a daily basis. And where do they go with their own? There is nowhere.
Wow.
So the groups that I run are a place where physicians who are, even they're stressed by normal life, maybe they're getting a divorce, or maybe, they've had to see, triple the number of patients because of COVID, or there's something going on in their own family. Maybe their mother is dying, and yet they still have to go show up for work. And maybe they're working with, patients who remind them of their mother.
Right.
So having a place to be able to openly talk about those things and have whatever feelings human beings have without shame and without any kind of judgment is profoundly healing.
Profoundly. And I also want to mention that your work is primarily in groups. And you and I both know that groups are such a healing modality. It's such a place of feeling less alone, feeling like you get a lot of feedback from others, that it's not just a therapist telling you, uh, not just one person, but it's a whole room full of people going through a similar situation. And in a way, what hit me about that was it's just like 12 step. When
Exactly.
somebody, yeah, when somebody hits bottom, it's time that they get help. And oftentimes it's actually a door to finding balance and well-being and really shifting one's life entirely. And I like what you said before about early intervention, because that's what we might call a higher bottom, where that before a lot of consequences happen, they get the help that they need, and then others are not so fortunate. Maybe their bottom is more difficult for them, but either way, it's kind of a silver lining, right? Because these people that make it to your groups are really starting a brand new chapter in their life, and having this opportunity, sometimes mandated and sometimes not, but this opportunity to find healing for themselves.
Yes. And as with most people who go into a 12-step program, the healing is on so many levels that nobody expects when they walk in the door. They really usually have a very circumscribed idea of what, quote unquote, the problem is. And oftentimes it wouldn't include them, it would be the circumstances that cause the problem.
Hmm. Hmm.
And being able to be with peers who can, gently and lovingly, and sometimes not quite so gently, but lovingly, um, share not only a clearer version of what, reality might be, but
Hmm.
also that there's hope to have a life that's better than they had even imagined for themselves, with the support and companionship of people who, again, are understanding, caring, loving, and supportive, non judgmental. Like, we could all use a group of people like that in our lives.
Absolutely. I couldn't agree more that it's something that in theory could be universal and universally healing for so many people. And I'm wondering, as we wind down our time today, if you have anything else that you would like to leave with our listening audience.
I think the idea that there are self care options that anybody, including very busy professionals, can take. And there are places that anybody, including healthcare professionals, can go for support is really important, because the problem often is the person feels very alone and very scared in a way, but perhaps ashamed of having some kind of secret, or not being able to manage, even the normal stresses of life, and not realizing that there are, options available, so that they don't have to walk through whatever the problem is by themselves. And just having that knowledge that there are places and options to help, I think, can be really helpful. And that just because you're intelligent and highly trained doesn't mean that benefiting from peers who understand that isn't can't be a profoundly life-changing experience.
Absolutely. So I just want to say again, it was such a pleasure having you here today. And I want to also mention to our listeners that you can be reached at your website, which is drtracyzemansky.com, and that's spelled DrTracyZemansky.com. And also, Dr. Zemansky can be reached at her phone number or office phone number, I should say, at 310-664-0454. And it's been so great to have you here with us. And we'll talk soon.
Thank you very much. It was an honor.
Thank you for listening today. It was really great sharing this time with my very talented colleague, Dr. Tracy Zemansky, and discussing this really significant topic that affects those affected by problematic sexual behavior and crossing of sexual boundaries. Be sure to give us a 5-star rating on iTunes, or please share our podcast on Spotify. And if there are any topics you would like us to discuss in the future, please let us know. I look forward to you joining us on future podcasts, and thanks again for being with us today.